Welcome to the deep dive. Today, we're tackling something really fundamental and honestly pretty revolutionary, the science behind chronic pain.
Yeah, it's a big one.
If you or, someone you care about has navigated chronic pain for years, it often feels like the science is sort of playing catch up.
That's a good way to put it, lagging behind the lived experience.
Exactly. But things have really shifted over the last decade, maybe a bit more. There's been this, well, profound change, evidence-backed. It's changing everything.
Everything is right, from how we understand the basic biology in the brain, right up to how diagnoses are formally made internationally.
And maybe most importantly, how we even define what a good outcome from therapy looks like.
That's our mission today, really, to kind of distill these major changes. We're looking at pain psychology, neurobiology,
Right.
and we'll do that by comparing the, let's call it the established foundational model, the one that really cemented psychological approaches around, say, 2017, comparing that with the big evidence-based updates that are shaping the clinical world right now in 2024.
So it's about how the core understanding of pain in the brain has shifted.
Yes, that plus the diagnostic tools we use and, like you said, the actual goals of treatment, they've pivoted pretty dramatically based on new data.
And the sources we're using today give us a perfect way to see that evolution, don't they?
They really do. We've got a foundational cognitive therapy framework sort of representing that pre-2017 thinking, laying out why psychology matters. And then we're putting it side by side with a very recent 2024 clinical report. And this report, it updates, critiques, expands on basically every part of that older model.
It really is the before and after picture. And honestly, the after picture is pretty exciting.
It is. There's a lot more hope, a lot more clarity.
So, bottom line, if you haven't really checked in on the science of chronic pain since maybe the mid-2010s,
Yeah, you'll want to stick around for this.
okay, let's start by unpacking that cornerstone of the older model, the
Yeah.
biopsychosocial model, the BPS.
Right.
For years, this was like the gold standard, wasn't it? It got us away from thinking pain was just about tissue damage.
Absolutely. It was a necessary step, a huge leap forward from a purely biomechanical view.
But let's be clear on why it was so important and maybe where it started to show its limits.
Okay. So the BPS model was crucial because it formally validated putting psychological and social factors right alongside the biological ones. I said they all interact. And this was really cemented by the definition of pain from the IASP, the International Association for the Study of Pain. Around 2012, they updated their definition.
And what did that say?
It explicitly defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage.
Sensory and emotional. That's the key phrase there.
Exactly. It established right there that pain is inherently subjective. It's multifaceted. It's not just some raw sensor reading from the body.
And before BPS, what was the dominant view? You mentioned biomechanical, but also operant conditioning.
Yeah, especially in terms of behavior. There was often a focus on a strict operant model. Pain behaviors, limping, grimacing, talking about pain, were sometimes seen mainly as being driven by reinforcement.
Like, you get attention, or you get to avoid chores or work, so the behavior continues.
Right. BPS really helped broaden that perspective. It didn't ignore behavior, but it brought cognition and emotion into the mix more formally.
So the cognitive rationale became central.
Hugely central. The foundational thinking was that a person's thoughts, their emotions, their specific behaviors, things like avoiding movement because you fear pain or constantly worrying about the pain, catastrophizing, these things don't just react to the pain signal. They actually profoundly impact the physical processes themselves and how well someone adjusts overall.
And that's where cognitive therapy, CT, came in.
Precisely. CD was established specifically to help people first recognize and then actively challenge and change those thought patterns that were seen as maladaptive, the ones amplifying the pain experience.
The logic seems pretty straightforward if you change the thought, like, this pain means I'm damaged forever.
Then you should be able to disrupt the negative emotional spiral, and maybe even some of the downstream physical consequences. It was a beautifully logical approach based on what was known then.
But for this BPS model to really take hold, especially against that purely physical view, it needed some kind of biological underpinning, right? Some brain science.
Absolutely. It needed a neurobiological explanation for how thoughts and feelings could possibly influence something as seemingly physical as pain.
Where did that start?
Well, the huge, truly revolutionary moment goes way back to 1965, Melzack and Wall's gate control theory.
Ah, the famous gate control theory.
Yes, this was the first major scientific pushback against the old idea that pain was just a straight wire from injury to brain. Simple stimulus response. Gate control proposed that the central nervous system, the brain and spinal cord, isn't just a passive receiver, it's an active modulator of pain signals.
Active modulator, meaning it can turn the volume up or down.
Kind of, yeah. The idea was this gate mechanism, mainly in the spinal cord. It can control whether a pain signal actually gets through to the brain to be perceived. And critically, they proposed that things coming down from the brain, cognitive factors like attention or distraction, emotional states like anxiety or calm, could influence that gate. Open it or close it.
Wow. So the pain you feel isn't just a direct readout of tissue damage, it's the result of this negotiation almost.
Exactly, that was seismic. It was the first plausible mechanism for mind-body interaction in pain.
And that evolved further, didn't it, into the neuromatrix model?
It did. Melzack himself later expanded on gate control with the neuromatrix model. This became really the theoretical engine powering psychological interventions for pain for a long time. The neuromatrix proposed that the experience of pain isn't located in one spot, but is generated by a widely distributed network of brain regions, this neuromatrix.
I know.
Yeah, integrating sensory input with cognitive information memories, attention, meaning, and affective information, like emotions and motivation. This really elevated the status of psychological factors. They weren't just reacting to pain anymore. They were seen as integral parts of the central brain process that actually generates the subjective feeling of pain.
So the neuromatrix provided the theoretical justification for therapies targeting the brain, like CT.
Absolutely. It legitimized the whole idea that you could change pain by changing thoughts and feelings because those were part of the pain-generating network itself.
Okay, so the models were getting more sophisticated, acknowledging the brain's role. But our sources point out a really big problem with how this played out in reality, this issue of delegitimization.
Ah, yes, this is crucial. And it's where the foundational model, despite its strengths, often failed patients badly.
How so? If the brain generates the pain but scans X-rays, MRIs show no clear physical injury, no structural damage, how did that message actually land with patients in the clinic?
Terribly, often. This is the core paradox, and it caused immense suffering for decades, and still does sometimes. Even with these sophisticated brain models, if a doctor couldn't point to a clear biomedical cause, a fracture, a badly compressed nerve, severe arthritis, the patient's pain was still frequently dismissed
Dismissed us.
as psychogenic, functional, sometimes even implicitly or explicitly as all in their head. The BPS model aimed to unite mind and body, but in practice, the lack of visible tissue damage often led to the conclusion that the pain wasn't real in a medical sense.
Or at least not something the medical system could fix in the traditional way.
Exactly. Which felt like being told you're making it up, or it's your fault, or simply we can't help you. It added this profound layer of insult to the already debilitating injury of chronic pain.
So if there's no identifiable fixable problem, what was the main therapeutic approach offered by that foundational model?
Well, it often defaulted to acceptance.
Acceptance, meaning just learn to live with it.
Pretty much. The core observation, the paradox noted back then, was that patients who somehow managed to achieve acceptance, meaning they let go of that constant, draining struggle to find a cure or eliminate the pain entirely, those patients actually reported lower perceived pain intensity, less emotional distress, and better day-to-day function.
So acceptance worked, in a way.
It did seem to improve quality of life for many. The goal shifted from fixing the pain to adjusting to the pain, learning to live a meaningful life despite it.
But that sounds, well, a bit like giving up, maybe.
It could certainly feel that way to patients.
Yeah.
And while pragmatic and genuinely helpful for some, this acceptance-focused approach often felt like a concession, a surrender to this mysterious, seemingly incurable condition. Crucially, the foundational model lacked the really strong, validating neurobiological language to explain why acceptance was helpful beyond just being a psychological coping skill. It didn't fully connect acceptance back to changes in the brain's pain processing itself.
And it's that gap, right? That inability to really explain why the brain keeps generating real pain even when the original injury is healed or was never clear. That's exactly what the newer science, the 2024 perspective, aims to fill.
Precisely. That's where the paradigm really starts to shift. Okay, so here we get to the real crux of the change. The field has moved significantly beyond just thinking about signal modulation, which was kind of the neuromatrix idea.
The brain turning signals up or down.
Right. Now, it's about redefining the brain's fundamental job. The critical neurobiological update is understanding the brain as essentially a predictive organ.
A predictive organ. Okay, let's really unpack that. This is the predictive processing PP framework,
Yeah.
sometimes called the Bayesian brain hypothesis. You said it's a massive leap. How so? What does it mean for pain if the brain is constantly predicting?
It means the brain isn't passively waiting for signals to come in from the body to tell it what's happening. Instead, it's constantly actively generating hypotheses or predictions, neuroscientists often call them priors, about the state of the body and the world,
Based on what? Where do these predictions come from?
based on everything it's learned: memory, past injuries, beliefs, expectations, even the current context. The brain basically builds its own model of reality internally, moment by moment.
Okay.
And then it uses incoming sensory data from the eyes, ears, skin, joints primarily to check if its current prediction needs updating. Is the world matching the model?
So it's like the brain is guessing what's out there and then checking if it guessed right.
That's a great way to think about it. Think of it like a very sophisticated, constantly running simulation. But crucially, like any system, it can sometimes make mistakes or become biased.
Okay, I think I follow the prediction part. How does that relate specifically to pain? What's the new conceptualization of chronic pain then?
The huge shift is this.
Hmm.
Chronic primary pain is generally understood not as a persistent bottom-up signal coming from damaged tissue that just won't switch off.
Which is what many patients assume, right?
Yeah,
Something must still be broken.
exactly. Instead, the PP model views it primarily as a top-down, maladaptive prediction. It's a protective inference generated by the brain itself based on faulty priors.
A faulty prediction of danger.
Precisely. The mechanism proposed for how pain arises is often described as a prediction error. Here's how it works. The brain makes a prediction, for example, moving my back is dangerous. Sensory input comes in. Example, signals from muscles and joints during movement. Now, if there's a mismatch between the prediction and the input, that's the prediction error. The brain has to decide, what does this mismatch mean?
Okay.
In chronic pain, the theory is that the prediction system has become biased towards assuming danger, often due to past experiences or learned associations. So it interprets that prediction error, that mismatch, as a sign of threat, even if the sensory input itself isn't actually indicating damage.
And the brain's response to perceived threat is...
To generate a protective output.
Yeah.
And the brain's primary protective output regarding the body, pain.
So the pain is essentially a false alarm triggered by the brain misinterpreting signals because its prediction system is stuck on high alert.
That's the core idea for chronic primary pain. The alarm system itself has become the problem. Its prior belief that there's danger is so strong that it overrides or misinterprets incoming safety signals.
Wow. Okay, that is a fundamental difference. The pain is still absolutely real, physiologically generated.
100% real. Generated by the brain.
But the source of the problem shifts from the tissue itself to the brain's interpretation or prediction about the tissue.
Exactly. It's a shift from a structural problem to a functional information processing problem within the nervous system.
Now, how does this connect to the physical changes? We talked about neuronal plasticity earlier. The 2024 model deepens this with central sensitization, right?
Yes, central sensitization, or CS, is really the key biological mechanism that underpins this state of maladaptive prediction. It's the neurobiological evidence of this learned, overprotective state. It's not just some vague plasticity. It's a specific, measurable state of nervous system hyperexcitability.
Okay, can you detail some of those specific biological changes? Because I think this is where it really clicks for people understanding the physical reality behind this brain trick.
Absolutely. This is crucial for validation. We're talking about concrete changes in how nerves communicate. One key mechanism involves the upregulation of NMDA receptors, particularly in the dorsal horn of the spinal cord. That's a major relay station for pain signals.
NMDA receptors, what do they do?
Think of them like amplifier knobs on the nerve cells. When they get upregulated, often due to persistent pain signals initially or even severe stress, it lowers the threshold needed to make that nerve fire. It's like turning the volume way up.
So a tiny input signal.
A signal that would normally be ignored, like light touch or normal movement, can suddenly be strong enough to trigger the pain pathway and send a danger message up to the brain. This helps explain how the system becomes hypersensitive.
And it's not just the neurons involved, right? The 2024 model emphasizes other cells too.
That's a critical update, yes. We now understand that glial cells, specifically microglia and astrocytes, which are usually thought of as support cells in the brain and spinal cord, play a massive role in maintaining central sensitization.
How do they do that?
When they get activated, often by those persistent danger signals or even by psychological stress hormones, these glial cells start releasing pro-inflammatory substances, called cytokines, directly within the central nervous system.
So inflammation inside the brain and spinal cord.
Exactly. We call it neuroinflammation. And this neuroinflammation doesn't just happen once. It can create a self-perpetuating cycle. It keeps the neurons hyperexcitable, contributing to widespread pain, often that feeling of migrating pain, profound fatigue, brain fog symptoms, very common in conditions like fibromyalgia.
So things like allodynia, where gentle touch becomes painful, or hyperalgesia, where a mild pain feels intense. These aren't necessarily signs that tissue's being damaged right now.
No. They're often direct, observable signs of a nervous system that has biologically adapted into an overprotective state. It's learned hypersensitivity, maintained by these neuroplastic changes in neuroinflammation. The defense mechanism is stuck in overdrive.
Which leads us directly to what you call the empowering new therapeutic narrative. This is huge.
It really is, because if chronic primary pain is fundamentally a prediction error rooted in this biologically maintained state of central sensitization, we can finally offer patients a coherent, non-stigmatizing explanation for their experience, especially for pain without clear damage.
How might a therapist phrase that?
Something like, look, the pain you're feeling is absolutely 100% real. Your brain and nervous system are physically generating that sensation. However, the latest science suggests that in many cases of chronic pain, the pain isn't signaling ongoing damage in your body tissues. Instead, it's more like a faulty alarm system. Your brain has learned, through past experiences or stress, to be overprotective, and it's now generating these danger signals, the pain, as a mistake, a false alarm based on an outdated prediction of threat.
That reframing feels like it could change everything for a patient who's been told it's all in their head.
It often does,
Wow.
because it validates the reality of the pain while simultaneously offering a pathway for change that doesn't rely on finding some hidden tissue damage.
And it shifts the goal of therapy.
Completely. It moves away from just coping or acceptance as the only options and towards the possibility of retraining the brain to update its predictions. The focus becomes actively teaching the nervous system that it's safe.
So therapy becomes less about managing symptoms and more about targeting the root cause, the maladaptive prediction.
Yes, and this neurobiological framing can really boost patient engagement. They're not just doing mind exercises, they're actively participating in rewiring your brain, desensitizing their nervous system through specific techniques.
And this predictive processing idea also helps explain why different therapies work, doesn't it? It offers a kind of unifying mechanism.
That's another major strength of the model. It suggests that many effective psychosocial interventions, whether they're primarily cognitive, behavioral, mindfulness-based, or even movement-based, likely succeed because they all, in different ways, help to generate that crucial prediction error.
Can you give examples?
Sure. Pain neuroscience education directly challenges the high-level cognitive prior, the belief that pain equals damage. Graded exposure, where you gradually reintroduce feared movements, provides direct, bottom-up sensory evidence of safety. The brain predicts danger with movement, but the movement happens without catastrophe. That mismatch, repeated safely, forces the prediction system to update. Maybe that movement isn't dangerous after all.
So different techniques, same underlying principle, provide the brain with strong evidence that contradicts its threat prediction.
Exactly. They all help the brain learn that the alarm is false.
Okay, so the science, the theory, took this huge leap with predictive processing. But for it to really matter day to day in clinics, the system around it had to catch up. The classifications, the diagnoses.
Absolutely. And that brings us to what you call the landmark diagnostic revolution. This is the formal medical legal recognition of this brain-based understanding of pain.
We're talking about the ICD, right? The International Classification of Diseases.
Yes, specifically the implementation of the ICD-11, which really started rolling out around 2022. This is a monumental change from the previous system, ICD-10.
Remind us what the problem was with ICD-10 for these types of pain conditions.
Well, in ICD-10, if someone had chronic pain without a clear ongoing disease or injury causing it the chronic low back pain where scans are mostly normal, or fibromyalgia, there wasn't a great diagnostic home for it. Often, clinicians had to use codes that implied a psychological cause, like F45.42, which was persistent somatoform pain disorder, or similar codes mentioning psychological factors.
Which, again, reinforces that idea that it's mental rather than physical.
Exactly. It implicitly framed the pain as secondary to psychological issues, or at least poorly defined. It didn't capture the idea of the pain itself being the primary problem, a disorder of the nervous system.
So how did ICD-11 fix that?
It was a complete overhaul for pain. First, it created a whole new top-level category specifically for chronic pain. And within that, critically, it introduced the brand new diagnosis, MG 30.00, chronic primary pain.
Chronic primary pain, what does that mean clinically?
It's defined as pain in one or more body regions that persists or recurs for longer than 3 months. And crucially, it's associated with significant emotional distress or functional disability. And this is key. It cannot be better accounted for by another diagnosis, meaning it's not just a symptom of, say, cancer pain or rheumatoid arthritis pain. The pain condition itself is the disease.
So conditions like chronic primary low back pain, chronic widespread pain like fibromyalgia, chronic primary headache, they now fall under this umbrella.
Precisely. They are officially recognized as chronic primary pain conditions disorders primarily of the nervous system's function, of its processing of sensory information.
What's the real-world significance of having this specific diagnosis, MG 30.0, for patients, for clinicians?
It's enormous. For patients, it provides incredible validation. Finally, their condition has a legitimate medical name, recognized internationally, that reflects the current science, that it's a neurobiological condition, not just in their head. It gives them a diagnostic home and combats that awful delegitimization.
Good for clinicians and the healthcare system.
It's huge for justifying and getting reimbursement for treatments. Having a specific ICD-11 code like MG 30.0 means we can bill for interventions specifically designed to target the mechanisms of chronic primary pain, like pain neuroscience education, or specific therapies like PRT we'll discuss, or intensive CBT focused on neurological retraining. These become medically necessary treatments for a recognized neurological disorder, not just optional coping skills for some vague psychological issue. It codifies the brain-based model into the system.
That institutional validation is critical. But the 2024 update doesn't stop there. It also demands we expand how we think about the biopsychosocial model itself, especially the social part.
Yes, this is a really important evolution. The foundational BPS model would list social factors, things like socioeconomic status, SES, race, neighborhood safety, education level, as important contextual factors influencing pain.
Right, they affect coping, access to care, stress levels.
Exactly. But the newer understanding, informed by research on stress physiology and health equity, demands we see these social determinants of health, SDOH, not just as context, but as direct biological drivers of pain, vulnerability, and persistence.
Biological drivers. How does poverty or racism literally drive biology?
Through the mechanism of chronic stress. Living with persistent poverty, housing insecurity, discrimination, lack of safety, exposure to violence, this isn't just psychologically stressful. It creates a state of severe, sustained biological stress.
And that sustained stress has physical consequences. This is where allostatic load comes in.
Precisely. Allostatic load is the concept that describes the cumulative wear and tear on the body's systems from chronically adapting to stressors. It means the systems designed for short-term survival, like the HPA axis releasing cortisol and the sympathetic nervous system releasing adrenaline, are constantly activated, running in overdrive all the time. Right. And that chronic activation leads to measurable biological changes. Persistent, low-grade systemic inflammation, metabolic dysregulation, cardiovascular strain.
And how does that connect back specifically to pain and the predictive brain?
This chronic physiological weathering directly impacts the brain regions involved in threat detection, emotional regulation, and pain processing areas like the amygdala, the prefrontal cortex, the insula. High allostatic load increases neuroinflammation within the CNS, makes neurons more excitable, and fundamentally biases the brain's predictive system towards anticipating danger. It makes the nervous system physiologically more likely to develop and maintain central sensitization.
So SDOH aren't just making it harder for someone to cope with pain. They can actually create the biological conditions that make chronic pain more likely in the first place.
That's the critical insight. Adverse social conditions get under the skin, literally, and sensitize the nervous system.
Which has major implications for therapy, especially standard CBT approaches. It forces us to adapt CBT for real-world constraints.
Absolutely. The foundational CBT manuals often implicitly assume a certain level of stability and resource in a patient's life. They assume the patient can realistically implement the homework, things like activity pacing, relaxation practice, thought journaling.
But if someone is facing extreme adversity due to SDOH,
Then those standard recommendations can feel completely out of touch, even invalidating. Imagine telling someone working 2 minimum wage jobs, struggling with childcare, living in an unsafe neighborhood, to find 30 minutes each day for mindfulness meditation, or gently pace your activities.
it sounds absurd. It could even damage the therapeutic relationship.
It absolutely can. It suggests the therapist doesn't understand the patient's reality. So, the modern, trauma-informed, culturally competent approach requires a practical assessment of SDOH upfront.
And tailoring the intervention accordingly.
Yes, it might mean that the initial focus of therapy isn't even on pain-specific CBT skills. It might need to be on foundational problem solving, helping the patient connect with community resources for housing, food security, or childcare, or addressing safety concerns first.
So stabilizing the environment before trying to retrain the nervous system.
Often, yes, or at least working on both concurrently with validation. The therapist needs to acknowledge that systemic stressors are biological contributors to the pain, not just background noise. You can't effectively teach the nervous system safety if the person's external reality is overwhelmingly unsafe or stressful. Ignoring the social context means you might be fighting an uphill battle against ongoing nervous system sensitization.
Okay, let's pivot to the therapeutic toolkit itself now, connecting these updated biological and social understandings to specific interventions. The foundational model, as we said, relied heavily on that stress appraisal coping model from traditional CBT.
Right. The focus was largely on identifying maladaptive appraisals thoughts like, this pain is unbearable, I'll never get better, and directly challenging or changing the content of those thoughts to reduce the negative emotional and behavioral consequences.
That's still valuable, isn't it?
Absolutely. Cognitive restructuring skills remain a core part of the toolkit. However, the 2024 landscape really emphasizes the integration of approaches, often called third-wave behavioral therapies. The most prominent one in pain care is acceptance and commitment therapy, or ACT.
ACT, it complements traditional CBT. How?
It brings in the central concept of psychological flexibility, which is a bit different from just changing thought content.
Okay, explain psychological flexibility. It sounds important, but maybe a bit abstract.
It is important. Essentially, psychological flexibility is the ability to do two things. First, to be open and willing to experience difficult internal stuff, thoughts, feelings, sensations like pain, without letting them completely dictate your actions. And second, to consciously choose your actions based on what you deeply care about, your values, and to persist in or change those actions in service of your values, even when it's uncomfortable.
So it's less about feeling good and more about doing what matters, even if you don't feel good.
That's a great way to put it. It pivots the goal away from needing to control or eliminate the pain before you can live your life, towards figuring out how to live a rich, meaningful life with the pain present if necessary.
This sounds like it directly addresses that paradox we mentioned earlier, where the constant struggle against pain often becomes a bigger source of suffering than the pain itself.
Exactly. ACT targets that struggle directly. It suggests that excessive focus on controlling pain can inadvertently shrink your world and disconnect you from what gives life meaning.
And how does ACT help build this flexibility? What are the core components?
ACT uses several interconnected processes. Things like acceptance, which isn't about liking the pain, but about making space for it, grouping the struggle with the sensation itself. Then there's cognitive diffusion, learning to see thoughts as thoughts, just words or mental events passing through, rather than literal truths or commands you must obey. This helps weaken the power of those unhelpful predictive priors we talked about.
So noticing the thought, I can't do this, instead of automatically believing it and stopping.
Precisely. And then crucially, clarifying values what truly matters to the person deep down, and using those values to guide committed action, taking steps towards that valued life, even small ones, even with discomfort.
So ACT provided a more robust, behaviorally defined way to achieve that acceptance the older models hinted at.
Yes, it gave specific skills and a coherent framework for cultivating that willingness and value-based action, connecting it directly to behavioral principles.
Okay, so ACT enhances our ability to live well with pain. But the predictive processing model opened another door, didn't it? The idea that maybe, for some people, the pain itself being a false alarm could be significantly reduced or even eliminated.
Exactly. And that leads us to the most striking addition to the toolkit, something really born out of the predictive processing framework. Pain reprocessing therapy, or PRT.
PRT. Now, this sounds different. You said it has a novel goal.
It does. PRT is pretty unique because it was explicitly designed to target the predictive processing mechanism. And its stated goal, for appropriately selected patients with chronic primary pain, is substantial pain reduction, or even elimination.
Elimination. That's a huge claim, directly challenging that long-standing acceptance message.
It is a direct challenge. It fundamentally shifts the therapeutic target for certain types of chronic pain. The underlying premise is, if the pain is predominantly a reversible learned neural pathway, a false alarm based on misinterpretation, then why should acceptance be the primary goal? Why not try to correct the misinterpretation and turn off the alarm?
That creates a real tension, doesn't it, between acceptance and elimination goals.
A huge tension that clinicians in the field are actively grappling with right now.
So how does PRT attempt to achieve this reduction or elimination? How does it leverage the predictive processing idea? What are the techniques?
One of the core techniques, perhaps the signature technique, is called somatic tracking.
Somatic tracking, what does that involve? It's not just mindfulness?
It's related to mindfulness, but it's more targeted. It involves guiding the patient to pay attention to their physical sensations, even the painful ones, but with a specific mindset, one of curiosity, lightness, and crucially, safety.
Safety. How can you feel safe while focusing on something painful?
That's the retraining part. The therapist helps the patient reappraise the sensation as they experience it. Instead of the automatic thought, oh no, this is damage, this is dangerous, the goal is to cultivate the thought, okay, that's just a sensation, it feels unpleasant, but my brain is generating it, and it's actually safe. It's a false alarm. The goal is to decouple the sensation from the fear response.
So you're intentionally trying to generate that prediction error we talked about.
Exactly. You're flooding the brain with corrective information in real time. The brain predicts danger when the sensation arises or when a certain movement is made. Somatic tracking involves experiencing the sensation or movement while consciously reinforcing messages of safety. See? The sensation is here, but I'm okay. Nothing catastrophic is happening.
And repeating that experience is key.
Repetition is critical. Each time the patient experiences the sensation without fear or without negative consequences, it sends a powerful prediction error signal that weakens the old threat association and strengthens a new safety association. It's essentially unlearning the fear and retraining the brain's interpretation of the bodily signals.
Is somatic tracking the only component?
No, it's usually combined with thorough pain neuroscience education, really helping the patient understand the predictive processing model and reconceptualize their pain as a brain-generated false alarm. There's also often work on reappraising fear-inducing thoughts and encouraging positive emotional experiences, which can further reinforce feelings of safety.
Okay, the theory sounds compelling, directly targeting the proposed mechanism. What about the evidence? Does it actually work?
The evidence, particularly from one major study, is frankly startling. There was a landmark randomized controlled trial published in JAMA Psychiatry in 2022.
Ashar et al., that's the one.
They looked specifically at patients with chronic primary back pain. They compared PRT to both a placebo injection and usual care.
And the results?
Of the one-year follow-up, 66%, two-thirds of the patients who received PRT were pain-free or nearly pain-free.
Wow, two-thirds. Compared
to only 20% in the placebo group and 10% in the usual care group. The effect size was huge.
that kind of result, it really does force a reconsideration of therapeutic goals for this population.
It absolutely does. It suggests that for a significant subset of people with chronic primary pain, substantial recovery, not just management, might be possible.
But this also puts a new kind of pressure on clinicians, doesn't it? It creates a really important clinical decision point.
Yes, exactly. The therapist can't just apply a generic BPS approach anymore. The modern pain therapist needs to be a more sophisticated diagnostician, really trying to determine the likely primary driver of the patient's pain.
Meaning,
Meaning they need to assess, is this pain likely secondary to ongoing nociception or inflammation? For example, someone with severe active rheumatoid arthritis or bone-on-bone osteoarthritis. In those cases, the pain signal is related to ongoing tissue pathology.
and for those patients.
For those patients, acceptance-based approaches like ACT, focused on improving function and quality of life despite the pain, remain the most ethical and realistic approach. You can't reprocess away the pain signal from an actively inflamed joint, generally speaking.
But if the assessment suggests the pain is chronic primary pain, fitting that MG 30.0 diagnosis, where it seems to be maintained by these learned neural pathways, central sensitization, maladaptive predictions, without ongoing tissue damage being the main driver.
Then a PRT-style approach, aiming for reconceptualization and potentially significant pain reduction or elimination, becomes a very viable evidence-based option to consider. The intervention needs to match the suspected underlying mechanism. That's the key shift.
Let's shift now to the broader clinical environment. Something else huge has happened that's changed the context for all of this: the post-opioid crisis era. How has that impacted the therapist's role?
It's elevated it dramatically. The widespread recognition of the dangers of long-term opioid use for chronic non-cancer pain led to major guideline changes. The most significant being the CDC's 2022 Clinical Practice Guideline for prescribing opioids for pain.
And what did that guideline say? It wasn't subtle, was it?
Not at all. It was decisive. It unequivocally stated that non-pharmacological therapies are preferred for most types of chronic pain, specifically naming things like cognitive behavioral therapy, mind-body practices, exercise, physical therapy. These are now positioned as the first-line standard of care, especially for subacute, lasting 1-3 months, and chronic pain. Opioids are reserved for specific situations, usually after non-opioid options haven't worked sufficiently.
So the psychologist or therapist moves from being maybe an optional add-on.
To being an essential primary clinician on the pain management team. Their skills are no longer just adjunctive, they're foundational care.
And part of that new, more central role involves helping patients navigate difficult medical transitions, like opioid tapering.
Yes, many patients who have been on opioids long-term are understandably fearful about reducing their dose. They worry their pain will become unbearable. The therapist plays a crucial role in managing those fears, providing education and supporting a gradual, collaborative tapering process when appropriate.
What kind of education helps? How can a therapist provide a rationale for tapering that isn't just about risks?
One really important concept to explain is opioid-induced hyperalgesia, or OIH.
OIH, that sounds paradoxical. Opioids causing more pain sensitivity.
Exactly. It's this phenomenon where, for some individuals, long-term exposure to opioids can actually make the nervous system more sensitive to pain signals over time. It can upregulate some of those same pain pathways we talked about with central sensitization.
So the very drug taken to relieve pain might eventually start making the underlying pain problem worse.
It's thought to contribute in some cases, yes. So the therapist can explain OIH and frame a gradual, carefully managed taper, not just as taking away medication, but as a potential way to actually reduce the nervous system's overall hypersensitivity. Understanding OIH gives patients a powerful neurobiological reason why reducing opioids might, counterintuitively, lead to a decrease in their baseline pain levels over the long run. It reframes tapering as a potentially therapeutic step for their nervous system.
Okay, so the therapist's role is bigger. What about the tools they use for assessment? The foundational texts mentioned PROMIS, the patient-reported outcomes measurement information system, as being promising back then. Where does that stand now?
Promise isn't just promising anymore. It's fully realized and has become the industry standard in many settings. Those item banks collections of carefully tested questions covering key domains like pain interference, pain intensity, pain behavior, physical function, depression, anxiety, fatigue, sleep disturbance, pain catastrophizing, self-efficacy. They're all finalized, validated, and widely used clinically and in research.
So we now have good, standardized ways to measure all those different facets of the BPS model.
Yes, high-quality measures that allow us to track progress consistently.
But aren't questionnaires often long and burdensome for patients and clinicians? That's always been a barrier to routine measurement.
That's where the technological leap comes in. Computerized adaptive tests, or CATs. This has been the real efficiency revolution for Promise.
CATs, how do they work? They use algorithms.
They do. They're based on a sophisticated psychometric approach called item response theory. Basically, instead of giving every patient the same long list of questions, the computer selects the next question based on the patient's answer to the previous one.
Adapting in real time.
Exactly. If you strongly endorse the first couple of items about, say, pain interfering with your life, the algorithm knows you're likely high on that domain and jumps to asking more severe level questions to pinpoint your exact level quickly. If you deny the first items, it might ask easier ones or quickly determine you're low on that scale.
It's a Bayesian approach, constantly updating its estimate of your score.
And the benefit is
Massive efficiency. CTANs can achieve very high measurement precision, meaning the scores are accurate and reliable, often with just 4 to 6 questions per domain.
4 to 6 questions, that's it.
Often, yes. Which means you can assess multiple crucial domains: pain, function, depression, anxiety, fatigue, comprehensively, in maybe 10 to 15 minutes total. This makes routine measurement-based care tracking outcomes systematically at every visit actually feasible in busy clinics. That's a game changer for tracking progress and tailoring treatment.
Absolutely. And it standardizes communication, too.
How so?
Promise measures all use standardized T-scores. The average score in the general U.S. population is set to 50, and the standard deviation is 10. so everyone speaks the same language. A T-score of 60 on anxiety means the patient is one standard deviation above the population, mean moderate severity. A T-score of 70 is two standard deviations above severe.
So a clinician can quickly see the level of severity and track changes over time in a very clear, quantifiable way.
Exactly. It helps with clinical decision-making, communicating with other providers, and even justifying treatment to insurance companies.
Okay, so we have better, more efficient measurement. The final piece, connecting back to treatment selection, is using this assessment data not just to describe the patient, but to be prescriptive and mechanism-based.
This is really the ultimate goal of modern assessment in pain psychology. We're moving beyond just describing symptoms and towards identifying the primary psychological or neurobiological process or mechanism that seems to be driving the pain and disability for this specific patient.
Precision medicine for psychotherapy.
Kind of, yes. The idea is to use the assessment data to guide the choice of intervention, targeting the mechanism that's most active for that individual.
Can you give some examples of how that works?
Sure. Let's say a patient's assessment profile shows a particularly high score on the Tampa scale for kinesiophobia, TSK-11, which measures fear of movement or re-injury.
Okay, so high fear of movement.
That assessment finding immediately points towards the fear avoidance mechanism likely being a major driver of their disability. They're avoiding activity because they fear it will cause harm or unbearable pain.
So the intervention should target that fear.
Precisely. The clinician would prioritize interventions like graded exposure, systematically and safely helping the patient gradually confront feared movements. The therapy is laser-focused on disconfirming that fear protection, generating safety learning, directly targeting the identified mechanism.
Okay, another example. What if the assessment shows low scores on measures of psychological flexibility, like the AAQ2 or the Psychological Flexibility and Pain Scale, PFP, and the patient reports their life has shrunk dramatically around the pain?
That pattern suggests psychological inflexibility might be the dominant maintaining factor. The person is fused with thoughts about pain meaning inability, and their actions are overly constrained by trying to avoid discomfort, pulling them away from valued activities.
So the treatment focus shifts.
Yes. In this case, the therapist would prioritize ACT techniques, things like values clarification, getting clear on what really matters to the patient, and cognitive diffusion exercises to help them unhook from limiting thoughts, and committed action planning to help them take steps towards those values despite the pain. Again, the assessment targets the mechanism, which then guides the intervention choice.
One more. What about high scores on the pain catastrophizing scale, PCS, especially the rumination subscale?
High rumination suggests a problem with attentional dysregulation. The person's attention gets stuck on the pain and associated worries, amplifying distress.
So the intervention targets attention.
Exactly. You might prioritize mindfulness skills to help them develop more flexible control over their attention, learning to notice thoughts and sensations without getting swept away by them. Or relaxation techniques to lower the overall arousal that often fuels rumination. The assessment prescribes the likely most effective starting point. #tag outro. So pulling it all together, this deep dive really shows a field in rapid, exciting evolution over these last, say, 7 years or so. The fundamental understanding of the brain's role has shifted from just modulating signals in the neuromatrix to actively predicting and sometimes mispredicting threat,
And that new brain model provides the strong neurobiological basis for chronic primary pain.
which is now formally recognized in the ICD-11, validating it as a potentially reversible disorder of nervous system function, not just a psychological issue or unexplained symptom.
And our therapeutic toolkit has expanded and become much more personalized.
Right. We now have ACT focusing on psychological flexibility for living well with pain when needed, alongside newer approaches like PRT, born from predictive processing, which offer the potential for substantial pain reduction or elimination for those with primary pain conditions.
Yeah.
And our assessments are getting smarter, helping us target the underlying mechanism for each person.
It feels like this really solidifies the value of skills-based psychological and behavioral care like never before. It's not the alternative or the last resort anymore.
Absolutely not. For many types of chronic pain, particularly primary pain, these approaches addressing the brain's maladaptive protective predictions, retraining the nervous system, building flexibility, are the science-backed, first-line standard of care. It truly elevates the role of the therapist or psychologist to being a primary essential clinician in pain recovery.
It's a much more hopeful picture, scientifically validated.
It is, but it also leaves us with a really important, maybe even provocative question that the field is wrestling with right now. For decades, the core message, especially from the foundational models, leaned heavily towards learning to live with pain, emphasizing acceptance as the primary path forward. But if the new science is right, if chronic primary pain is often, in essence, a reversible brain-generated false alarm, a learned prediction that can be unlearned through targeted interventions like PRT,
Um,
then does that long-standing focus solely on acceptance become maybe ethically insufficient for some patients? If the pain mechanism is potentially reversible, should our ultimate goal always be acceptance, or should the elimination or at least significant reduction of that maladaptive threat prediction be the primary target whenever feasible? Is psychological flexibility the ceiling, or is resolving the false alarm the true measure of success when possible?
that's a profound question. Acceptance versus elimination, based on the type of pain.
It's the core tension, I think. Where do we set the therapeutic horizon? It's something for all of us, clinicians, researchers, and maybe especially for you, the listener, to really mull over as this science continues to rapidly evolve and redefine what recovery from chronic pain might actually mean.